The way I presented my talk that I think helps is to break it down into four main areas: pre-hospital advances, the theater hospital advances, in-route care patient movement advances, and then a little bit of kind of a general potpourri of those that don't fit into the three. So pre-hospital advances that were made, the Committee on Tactical Combat Casualty Care formation, the Defense Health Board. That was stood up basically saying that we need a way to minimize preventable deaths on the battlefield and yet accomplish the mission. And we need some guidance about what should be done when, and also that we also need to have constant improvements out of that. So there's going to be new devices and new technology. Our tourniquet use, the CAT and soft T tourniquets were a big improvement there for extremity hemorrhage, for stopping that. We have new hemorrhage control tourniquets now for hip and shoulder amputations that are being developed. So we're constantly improving. So that tactical combat casualty care guidance and formation and the incorporation of that course material into the pre-hospital trauma life support. So that was a key pre-hospital one. I think another part that certainly kind of goes along with that in smaller ways is the tourniquet use. We know in Vietnam there were tourniquets used, but they were not really, they were field expedients. Were not very quick to use, they weren't effective, they were bulky and difficult to use. So those have been a great success. We know at the point of injury that the lethal triad of hypothermia, acidosis, and coagulopathy, of those things that we can do there, we talked about not having them become acidotic because we've stopped the bleeding using a tourniquet and direct pressure. We've also learned that from pre-hospital exposure that using hemostatic H's, some of the things like the combat gauze or the old quick clot, the HemeCon, celiac, that's technology that can go in and stop bleeding for something a tourniquet can't be used on, a non-compressible site. Another win that goes along with that. The pre-hospital stabilization of that patient has been key. Start learning that we need to keep them warm. The ready heat blanket that we can open up and put around that patient that actively rewarms them prevents that coagulopathy and that lethal triad from happening. So those are our quick wins. I think after pre-hospital, the in-hospital care, things that have been going on from the surgeon's perspective, things like damage control, resuscitation, the ability to understand that we need to get a person to the OR, do a quick clean out and stop the hemorrhage, stabilize fractures, and then back to the ICU to continue the resuscitation and warming, and then back to the OR when they can tolerate it, and do that in a phased approach versus a one-time. Damage control, resuscitation, another big win. We also have learned about resuscitation fluids. We used to give a lot of crystalloid IV fluid, such as lactated ringers or normal saline. We learned that doesn't provide oxygen carrying capability, and it dilutes our clotting factors of the blood, both of which don't help our patient. Giving them packed red blood cells also along at the same time with plasma and even platelets, that one-to-one resuscitation formula now provides them with the things that they need in a more proactive manner. We used to kind of give packed cells, we'd draw our coags, we'd wait maybe 15-30 minutes to get abnormal coag results, and then we'd start giving plasma. So we've been proactive in that. That's made a difference in outcomes. The other thing that I think has been a big win from the formation of the clinical practice guidelines, things that give us to know what type of care these special kind of patients need, because these are patients we don't see in a civilian setting. In a car crash, you don't see people come in with both legs traumatically amputated, their arm degloved or amputated, blast lung injury, maybe even abdominal evisceration or something that way, and also head trauma. That just doesn't happen. So from the care team perspective, the surgeons and the nurses, we need to understand what needs to be done, how, and at what point in the timeline, because not everything needs to happen, ought to happen at one time. Those clinical practice guidelines from the last 10 years of lessons learned, from the continual process improvement and keeping our eye on what's going on and how they were treated and how did they turn out, has helped us to provide those practice guidelines so that we're having a lot better outcomes with our patients. Not making the same mistakes now in 2013 that were made in 2005 and 2006. That's a huge win. So those are the key ones, I guess. The en-route care, the establishment of the critical care air transport team for the Air Force, people that can now move stabilized patients, patients that have a secure airway, their bleeding has stopped, their fractures are stabilized, initial resuscitation has begun, but they're not stable patients. But we know that we need to free up those beds at the hospitals in the theater of war to get room for more patients, so we need to move them out quickly. Well, obviously that patient's on a ventilator, they're still unstable, they need to have a critical care doc, nurse, cardiopulmonary technician there to manage all their patients' needs and equipment that are going with them. That CCAT team working now in conjunction with the AirVac team together as a partnership, great win. And that happened in 1995, so that's a recent advance that now we've seen the effects of that during this war. We've seen the advancement of better pain management for our patients by the use of patient-controlled analgesia, or PCA pumps. Now those AirVac missions where people had pain management issues that the nurse would have to go through and get out their narcotics box and document giving those pushes. Now we've got something that the patient can control, and that now they have more instantaneous pain management, and it also frees up the AirVac crew for other patient requirements. As well as the advanced anesthesiologist can go in there and do a peripheral nerve block and actually provide anesthesia to that limb or part of the body that's still traumatized. And now that patient has even better pain management and decreases their amount of opiates that they have to have for analgesia. So that long term, we know that the better we manage their pain and the sooner we manage their pain, the less PTSI symptoms they're going to have and less severe symptoms they'll have later on. So those are key things. We're making improvements in our en-route care with rotary wing. You know, the Army's Medevac system, flight paramedic program to now increase the level of training in the flight medics, adding critical care nurses as an additional attendant with that flight medic on some of those flights for those patients that are really badly wounded. That second set of hands, that critical care experience, invaluable. So that certainly is a big win. And then as we kind of go to the general category, things like the Joint Theater Trauma System, the application of the American College of Surgeons Committee on Trauma recommendations for this resources for optimal care of the injured patient that says you need to have a trauma system, continuous process improvement, continuous training. Well, you know, some very smart people said we can do that in the theater of war. We can establish trauma centers. We can now bring that patient right to the trauma center instead of stopping them at every small little aid station or maybe an FST along the way, as long as we have air superiority. It's not that much farther. We get them right to where they need to go, full medical care, CT, all the surgical specialties there, ICU, and they have robust resources to continue to care for them and stabilize them, and then move them out of the theater, usually to Landstuhl, Germany, and then back to the States. That's a huge win. That Joint Theater Trauma System, continuous process improvement, the Joint Theater Trauma Registry, the data collection that allows us to do evidence-based decision making, lets us know, are we making progress, and what things still are we having not making the success that we'd like to have. Things like potentially survivable or preventable deaths. We know that tension pneumothorax, hemorrhage, those are two things that we should be able to do a better job with, and the data is what's telling us that. So many other wins in the generalized as well. I mean, our ballistic eyewear has decreased our eye injuries, and now we've seen all the Oakleys and the ESS and all the other manufacturers that are making a lot of great eyewears that translates into a win for civilian population. Our prosthetic care, guys come back horribly, injured through the loss of their legs, but through a lot of research and development, Center for the Intrepid, applying these new prosthetic applications. Those are now applicable to people who maybe have a bone cancer and have a leg amputation. Now they've got all these neat prosthetic options to mountain climb, to bicycle, carbon fiber to run triathlons with. All that stuff is a direct result from our improvement in the advances in the care of the combat wounded patient. There's probably more, but certainly there's just so many things that we have learned over there. And now those are applied into the civilian setting to improve our care of civilian trauma patients. Okay. Aeromedical evacuation is movement of patients on a fixed-wing aircraft. It's led by the Air Force. The Army's medevac is on helicopters, and it's usually short distances moved in theater, usually from point of injury to a stabilization point for a surgical team or hospital. The Air Force's air medical evacuation, though, takes them from an air hub and then moves them out of the theater to the States or maybe an en route facility like Launchstool. Well, we have patients, obviously, that are not going to get off the ventilator anytime soon in the hospital and the theater. And those beds are at a premium. You know, as more casualties come in, those beds have to be made available for those casualties to be received. So those patients that are on ventilators have to be transported out of there. So the idea was, well, the air-evac crew doesn't have the training, the manpower, or the time, really. I mean, they're talking air-evac missions with up to 60 patients on there. They can't be taking care of that ventilated patient. So they said, we need to have some critical care attendants. We need to basically have a mobile ICU, the ability to create an ICU environment, small as you will, limited resources, but yet the same ability of an ICU on that air medical evacuation aircraft and on that mission. And so that was really General P.K. Carlton, as well as a number of other people back in the early 90s. You know, there were many things going on. Gulf War I was happening, Mogadishu was happening, and they said, gee, we need to have this capability. And through a lot of effort and real tenacity, those folks didn't let go of the concept, and they pushed it through. And as a result, today, all those ICU patients that would have had to either have more beds made available or something like that, would have stayed in theater until they finally were stable enough to be moved by an AE crew. Now, within 24 hours, we can have them out of the theater and on their way back home to their family and all the main tertiary care facilities in the States. So that was a huge, the critical care air transport team concept. Huge, huge win. Well, sure. We've moved in the last 11, 12 years over 100,000 patients using the air medical evacuation system. Of those, about 20,000 were critical care patients, required a critical care air transport team as medical attendants to take care of them. So the cost of that is you've got to keep those critical care personnel, the nurse, the doc, and the respiratory tech, cardiopulmonary technician, current and critical care skills and training. So, but many of those are people that already are doing those jobs as it is in a stateside ICU. So not a great cost to their skills are already required and needed, so those are things that are already managed. And then moving them into the theater, awesome. You know, as well now, we take a gap in those positions, those people in the ICUs in the States that we're taking them from to fill those wartime taskings. So they have to be filled or maybe, increased. So there is maybe a higher level. That just comes with wartime operations. So I don't know if I could put an exact cost on what that would be, but look at the difference of a ICU patients in theater who's now moved within 24 to 48 hours back to the States versus someone who might have had to stay there for days, even weeks before. Well, obviously, it's great to rub shoulders with, because everyone in some capacity has some contribution or story with our wounded care for our wounded warfighters. To me, that's really the greatest satisfaction. When you have one of our young sons or daughters, patriot, serving their country, trying to give freedom to a country and a people that have known very little freedom in their past, and through the results of terrorists, insurgents have damaged them, some horribly damaged, traumatized, to be able to go up to them and to tell them, hey, I've got you, you're safe, you're out of harm's way, I'm not going to leave your side, we're going to get you back home, back to your family, back to your friends in the States, so that you can get back with your care. That's as good as it gets. And everyone here, in some fashion or some role, is providing research or direct patient care or some type of administrative support to ensure that those wounded warriors get the best crack at getting as much back as they can get. We don't know what kind of mental status that patient's going to be. All I know is that since I don't know that, and even if I did say that, your mind may change. My job is to give you the very best fighting chance and to keep you as healthy as possible. So when you come back to the States, you have the most to work with to decide, what can I do? How my life is now different. what can I do with this different body?